I have red wax in the occlusal embrasure space, right? Get my little pointer. The teeth contact here. And I have red wax, not completely filling the occlusal embrasure space, but it's in the occlusal embrasure space generally. All right, it looks like that little triangle kind of, right? What I have on my PowerPoint. But if I look at the occlusal embrasure space from this view, it's this whole entire space formed by, it's a little thick right there, but you know, it lies right there. That's my occlusal embrasure space, right between the teeth and above the contact. It's hard to get a real thin piece of wax in there, but it's that little space formed right here above the contact where we place the floss first. Does that make sense? Do the incisal embrasure space. There's that little V-shaped incisal embrasure. If I look at it this way, it's right there, incisal to the contact. Okay. Now, if we go to the buccal aspect, I'm going to go back to share my screen. All right. Okay, if we look at the teeth from the occlusal view, we're looking through the occlusal embrasure, and the space buccal to the contact area is called the buccal embrasure space. Okay, so those blue triangles are on the buccal aspect of the teeth. All right, so you can imagine if I'm chewing food, it's going to flow through these little sluways here. What do you see? Do you see Elmo? No, you see my PowerPoint, all right? It's going to flow through this spillway here too. These are the lingual embrasures. So when dentists create crowns for teeth or restorations, they need to restore these contours. And some dentists do it better than others, all right? Some dentists do it to such an exquisite level, it's unbelievable. Others do not. And their work can be a little bit sloppy, okay? So if we look at the buccal embrasure again, here's my model, all right? And here's the wax filling this buccal embrasure space. If I look at it from the buccal aspect, it's this entire region here. Okay, so it's a very three-dimensional thing. So if you work for a doctor who doesn't have that artistic ability and the discipline to really restore tooth shape and form, you're going to have a patient with more problems keeping their gums healthy, removing plaque, and so on. It's amazing. I filled in for a guy this summer, and I mean, I have seen work that beautiful maybe twice from two different offices in the past, and it was incredible. He bought the practice from an office where the dentist wasn't very good. They were not good. They put big old boxes on the teeth, and they did not reform these embrasures. The gum tissues were always bleeding as the hygienist trying to get under the edges of these bulky crowns. Really, really hard to work with and really get our patients healthy. So this guy is like amazing. In fact, he'll put things on, and if he doesn't absolutely like it, if he's not perfectly happy with it, he will take it off and redo the whole crown again, or bridge, whatever. So he's kind of like really, really amazing. And the key is when I see patients who have work like that done, I say, you know, these crowns are absolutely beautiful. And I don't mean they're pretty. You know, I tell them, you know, the doctor who placed this took the time to really create the shape of the crown so it supports the health of your gums and keeps your mouth healthy. And then that helps you keep that crown longer because you're less likely to get decay under it. So all these things are important. Let me go back to the PowerPoint. So the interproximal space, oh my goodness, what did I do there? Hold on. Is cervical to the contact area. Okay, it's formed by the contact, by the surfaces, the mesial and distal of the teeth, approximating teeth. Okay, so from the contact, the distal and mesial surfaces of the approximating teeth, and then underneath by the crest of bone. So if I draw the bone in here, so the triangles are pointing to the interproximal space actually, okay? So it's this little triangle right in between the teeth. That is the interproximal space, and in health, it is filled up with the gingival papilla. Right? It's got a papilla in every single one of them. That's the interproximal space. Now, this space is important because if it's ideal here, as you see in this x-ray where the papilla would be right here, that space enables really nice thick interdental bone here. And you see that that's more supportive bone to help keep that tooth in place. If you have teeth that aren't lined up well, so let's pretend this crown was up to here, this tooth was erupted, you'd see there's very, very thin bone. That patient gets an infection here. It's going to wipe that bone out so fast, so much faster than it could this thick interdental bone here. All right, so we like to see these nice spaces occur, and sometimes they're not only affected by dentistry, but they're affected by alignment of teeth. The teeth don't line up right in the mouth, then these embrasure spaces are not going to be optimal. The amount of bone between teeth won't be optimal, and the patient's going to have more difficult time cleaning the teeth. So let's look at a case here that has no papilla left, right? This is due to gum disease, and it has destroyed the entire papilla here. They probably got a 6 millimeter pocket down through here, okay? This then is referred to, just like those other empty spaces, as an embrasure. This is an embrasure. It's a space, it's an empty space. Its interproximal space is filled with gingiva. The embrasure is air. You could drive a Mack truck through there, right? So we classify embrasures when they, spaces actually. And I'm going through what types of home care devices you would recommend for them, because boards loves to ask you these questions. So the spring of 2022, when you're preparing for your boards and you go back and read my packets for your dental anatomy, you'll see it here and it will remind you, because you're going to cover oral physiotherapy in spring of this coming spring, you know, with Mrs. Smiley's class. I'm not going to test you on these OPT aids. I'm not going to test you on it. I'm putting it here for your information right now. And as to why do we look at whether or not the papilla fills the interproximal space or not? Because it's going to determine what you tell the patient to do to clean that area at home. So type 1 is an interproximal space like this one, where that papilla completely fills that area. Type 1, ideal, just like class 1 occlusion is ideal. Type 1 embrasure is a healthy embrasure filled with gingival tissue. Type 2 has a little bit of recession of the interdental papilla. So here you see this black triangle. There'd be a black triangle here too if it wasn't filled up with spit. Okay. And here too, if we could fully see it, there's an open embrasure here. So this is a type 2 embrasure space because we have a bit of a papilla. If we compare the CEJs, you know, we have some papillary tissue there. And then generally when a patient loses a papilla, that's it, it's gone. There's underlying bone loss as well associated with that. But when you see this, what is recommended, and these pictures are from your Wilkins textbook, there's certain things to use. Floss isn't the recommended device anymore because these spaces are bigger. Get the biggest thing you can between there. So this is like a wooden Stimudent over here. And then this is what we call an interproximal brush or Proxibrush. They come in different sizes, and we'll look at that. But get those bristles in there, really clean that area. Get the biggest thing you can in there to keep it clean. A type 3 embrasure is this, and again, that's the worst it can be. And you see that loss of papilla is right to the CEJ facially. So that's extensive recession or complete loss of the papilla. And you might even use a little toothbrush in there. This is a tufted brush. You see, it's just got a couple little, it's like a piece of a toothbrush. It's really, really a great device, easy to use, or a large or wide Proxibrush brush, which is what this is down here. So again, we look at this, we need to determine, students say, well, I taught them how to floss. Well, flossing is hard. This person obviously doesn't floss, never has. Let's just get them in there, get in there with a Proxibrush. It's so easy. Or a tufted brush. It's so much easier. Why give them the hard stuff? When actually it's not even ideal. So this is from your Wilkins textbook. There's all kinds of thicker and different dental devices, some, tufted floss. Here, you see it's a thicker cushioned kind of floss for open spaces here. Here's the Proxibrush going in between the teeth and reaching these root concavities better. And you see the Proxibrush coming from the labial here, whereas floss is just this little piece. The Proxibrush is great. And the Stimudent is great too. And then these are the different sizes of interproximal brushes too. These things are awesome. I don't know if you've ever seen a gum soft pick, but this one here, especially, holy mackerel, that is a unbelievably wonderful device. I use it through all of my mouth. It's easy to use. It feels good. It really feels good. So if you see these, get some. If you don't like them, I'll buy them from you because I love them. These have a little wire in them, these Proxibrushes here. These have a little wire here and then these bristles. I don't like the feel of the wire, and it may be that I don't have real large interdental spaces like these would require perhaps. So how would you classify the cervical embrasures here on the left side of the screen? Are they 1, 2, or 3?
2.
2.
Exactly. It's a class 2 cervical embrasure. How about this side on the next picture? That is a pretty pink picture, isn't it?
3.
That's a 3. Now it looks like there's papillae here, but actually what it is that's such extensive facial recession. So they virtually have no interdental papilla here. So that's a 3. Proxibrush in there, huge. So that's cervical embrasures, other types of embrasure spaces. Critical to healthy dentition is maintenance of optimal embrasure spaces. Height of contours are also important, and we've talked about them on all of the teeth. And they produce a healthy flow of food from the crown onto the gingiva, so that it stimulates the gingiva. Now, you really don't think about eating causing stimulation of the gingiva, but it does clean away plaque and it stimulates blood flow. You know that the facials are in the cervical thirds, those heights of contour, as you see here, 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 okay? All facials. On the linguals of the anteriors, the height of contour again is in the cervical third. This is very inflamed gum tissue. That gingiva should be knife edge to the crown. These are swollen, rounded, inflamed tissues. And then, the chewing of food actually becomes traumatic to them, which doesn't help either. If it just keeps banging it into the top of that gingiva, it becomes less of a healthy stimulation. Some of it gets retained perhaps underneath the gingiva margin too. On the posterior teeth, the lingual height of contour is in the middle third of the crown. And I can't really show you that here because this is mesial and distal here. So what happens when these heights of contour change? So here is the cervical third of the crowns here, okay, and here. All right, now on my clinical crown, that height of contour is in the middle third, and look at the debris up here. Okay, the mesiobuccal root's more prominent. They can't get around that well. They're not getting around that well with their brushing, and they trap all kinds of schmutz up here. All right. Same thing here. You see a little white material up under here as well. So having them there is important. Here's a patient who has a lot of gum recession here and here. So again, the heights of contour are here. They're no longer in the cervical third. And actually under this is this undercut that traps a lot of bacteria. So when the patient bites into something, it hits off of that height of contour and then goes over the gum. It doesn't help clean this region at all. So you really have to address this with patients and show them that, you know, look, this is a tough little site. You really have to angle your bristles of your toothbrush there very deliberately. Same thing interproximally. Heights of contour here are up here. Okay, there's the cingulums. Here and here. And you see all of the debris underneath those cingulums because again, there's no natural cleansing of these teeth because it's bouncing off the height of contour and sliding right beyond all of this exposed root surface, which is more narrow below that cingulum. So that's a huge impact on the dentition. What is also shown here is altered proximal contacts because of crowding. We no longer have a contact in the incisal edge here. This contact area is, let me see if I get this color changed. Yeah, this contact area is all the way down here like this. That's not ideal at all. Okay, you see the shape of the gingiva is affected by it. Here we have a contact up here, but on this side, the contact area is all down here. This is contacting all down here. Very difficult for you and for your patient. It affects the embrasure spaces and how well they contribute to the self-cleansing of these teeth as we eat. And it just makes your work is going to be very difficult around teeth like a bit like this. I tell the patients, you sure, I'll bet you love seeing me struggle with this just like you do at home, right? But they need to understand how to get down under this undercut beyond these cingulums with their brushing. And if they can't do it with a regular toothbrush, I have patients use an end tuft down here. Anything just to get down in there. They need to feel the bristles along the gum line. The worst height of contour alteration, orthodontic brackets. Now the heights of contour in these middle thirds. Look at this gum tissue. Look at it over here. Look at it here in the middle. These teeth surfaces here are covered in gobs of plaque. And again, the rule about drying the teeth was not followed. Here, the gum tissue is all up under the wire, swollen up to here. Little cleft here, all up under here. This is all swollen gum tissue. So the patients have to be taught how to clean well, cervical to these brackets as well as occlusal, because there's no normal flow of food. The food hits these brackets, boom, it's done. It's not hitting here at all. So it's a big deal with patients in orthodontics. That's a pretty cool picture, isn't it? So also with these teeth, there are some curvatures that are ideal. And we need to know about them because it's going to assist us in evaluating tooth position in the dentition. And we know that when the curvatures, not only of the crowns themselves, but also of the position of the teeth on their long axes, okay? If you look at these images, you see the arrows are following the long axes of these teeth. And you see they're going in all different angles in the maxillary and mandibular picture here. That's called axial inclination. And they produce these typical curves that you need to know about. One is the curve of Spee, and that is an imaginary line, and it forms a gentle curvature, ideally along the cusps of the molars to the incisal edges of the incisors here. All right, and you can see, for one thing, this tooth is beyond the curve of Spee here, right? So it helps you in that evaluation. There's another curvature. So if the curve of Spee we look at from the side, the patient's cheek side, all right, we'll look at that in our dental x-rays. We used to use that to know where to put an x-ray, and it's in the film x-ray in a mount, not so much a big deal in digital, but we still look at it in evaluating a malaligned teeth. The next curve you need to know about is the curve of Wilson. And the curve of Wilson is shown here by this curvature connecting the cusps of these inclined molar teeth. And the cusps are placed so that if we connected them, they would form this beautiful curve here. So we're looking at the face of the patient here. This is the tongue, okay, here. And here are the mandibular molars. You see that curvature. You see it down here on the mandible of the skull, okay? That's the curvature they're talking to, so that a ball would rest on the occlusal surfaces of the teeth. It would be perfect, perfect size ball, but there's that ball. We can draw it all the way around. If we had a ball like this, there you go. But again, it's because the teeth do not stand perfectly upright like slats in a picket fence. I know I'm running a little over here, but this is just about the last. So here is a three-dimensional combination, the sphere of Monson. So it combines the curve of Wilson in this direction and the curve of Spee in this direction. And if we combine them three-dimensionally, we have the sphere of Monson. I've never seen the sphere on a board exam or heard of it being on a board exam, but who knows, it may be. But again, that's this giant three-dimensional sphere that would rest on the mandibular arch due to the axial positions of the teeth. And it's just something you will have to memorize. Tooth position affects gingival contours. It can make it thicker in some places and make a tooth prone to recession. So here we see this tooth is lingually inclined. You see the papillae are thick here and rather blunted looking, okay? This tooth over here is a little bit lingually inclined, and still we've got these thickened papillae here, but not quite as short a clinical crown as on the first tooth I showed you. This tooth is labially inclined. I'll put an LA on it. Okay, so that we see the CEJ is down to here. Okay, so again, this is affecting this tooth. Some people have teeth so labially inclined, they're very prone to recession, because we've talked about this in terms of the canines with the canine eminence. But when that tooth is very far anterior in the alveolar process, the bone and gingiva covering it can become thinned. And so it's much more susceptible to trauma and recession. And here again, lingually inclined, these thickened, irregular looking bulbous papillae. Okay, same thing here. Got these thickened papillae. And more ideal looking here on this tooth. Very thin attached gingiva there, right? These guys know about the MGJ. That one might be too labially inclined. Same thing here. These papillae on this one, that's kind of toward this tooth here, toward the lingual. This actually has a little crack here. Almost looks like a little butt, doesn't it? It's called a cleft. And it's important to know that, because when your patient does have these malaligned teeth, that when you look at your patient's healing from your treatment, if initially they have gum disease, there may be some things you just can't get to an ideally healthy state because of the malalignment of the teeth. And then here is the violation of the curve of Spee. Put Spee up here, okay? This tooth is in supraversion. It is erupted beyond the occlusal aspects of the adjacent teeth. So it is also called supraeruption, and it's also referred to as extrusion. This tooth is extruding or supraerupting into the space that this lower tooth once held. Certainly that lower tooth was taller than this. So you see it starting to collapse down that space. And I've seen teeth supraerupt so far, they touch the ridge in some cases. Okay, here again, you see malline teeth. You see that bulbous papilla and plaque retention. You just see it sitting in there. Same thing down here. And so that's it, guys. These are the normal curvatures. Anytime that ideal arch shape is compromised, it certainly does lead to potential increase in plaque retention, gum disease problems, tooth decay problems, and other things as well. But these natural curvatures, again, are very important. Okay, you work in an office where you see patients coming in, they got these bloody gums all the time, and it's, you have to think about, too, is it possible that it's related to the, in some places, some dentistry that's being done. Hopefully not, but not everybody cares about their work quality. All right. Okay, if you have any questions, let me know. So the written mid-final is on Monday. It'll be multiple choice questions primarily. And then the practical component will be during your lab on Thursday. And I'll have photographs of teeth, of models, of dentitions and things like that for you to, label in different ways. Okay, you may have to describe the tooth position. You may have to describe the occlusion, what tooth is missing, what tooth is deciduous and which one is permanent, and that sort of thing. Okay.
How many questions are on the midterm on Monday or the final?
It'll be about like the midterm. I haven't finalized it yet. There's a lot of work to converting these to what we're doing now. So I haven't quite finalized it yet, but I put on as many as I can to give you good opportunity, optimal opportunity to do well.
Thank you.
You're welcome. And it will cover all the topic areas of the course in an even manner. So it's fully cumulative. Okay, anything else? Okay, you guys. Good luck.
Thank you.
You're so welcome.
Thank you.
Bye.
You're going to do great. I know.